Good afternoon. Welcome to San Francisco, UC Berkeley Extension's Downtown Center. I want to welcome you to this afternoon's public lecture. And I want to welcome those in the room here today and to those joining us online. You'll hear a public lecture from Sarah Hooper and Dr. Lyle Duncan on the End-of-Life Option Act legal and clinical implications. And I might add, this is a topic that clearly has personal implications, I'm sure, for all of us in the future, and if not in the past. So my name is Stan Weisner. I direct the Behavioral Health Sciences programs here at UC Berkeley Extension. We offer a range of programs, workshops, courses in the behavioral health sciences. And today there's special interest for those enrolled in some of our programs that deal with issues, first of loss and grief counseling, which we offer workshops in aging and mental health, and we also have a professional program in health advocacy. We offer CE workshops and end-of-life issues in each of these programs, and some of our instructors are here today who teach in these programs. Joanna Smith, who sits right here, teaches a course, leads the program in health advocacy and teaches a course in this field in the fall. We also have Dr. Mindy Ginn, who teaches in the Aging and Mental Health series, and Dr. David Jill Johnson, who teaches in our Loss and Grief series. And in fact is teaching a workshop later this year on the End-of-Life Option Act, what mental health clinicians need to know. So before I move on, I want to mention that we are fully online today, and it's primarily being listened into by the UCSF, UC Hastings Health Policy and Law Master's Program. Sarah Hooper, one of our speakers, is the lead instructor in that program, and we'll be discussing that program a bit in her own comments. As I said, this program is being live streamed for those in that online master's program and others who couldn't be with us here today. So the session is being recorded and will be posted also on the UC Berkeley Extension website for those who would like to view it later or have colleagues review this session. I want to mention, as part of this public lecture series that we offer each year, we have the Dean's Office support, and I want to thank the Dean's Office for supporting this effort. Now, let me introduce our two speakers. Sarah Hooper is the Executive Director of the UCSF UC Hastings Consortium on Law, Science, and Health Policy, and an adjunct professor at UC Hastings College of Law here in San Francisco. Formerly, she worked at the law firm of Leif, Cabraser, Hyman, and Bernstein, a strong supporter of public radio, I should mention. Her research and teaching interests focus on legal issues in aging and dementia care, including healthcare decision-making and informed consent, capacity, elder financial abuse, the link between health and access to civil justice, which may be increasingly important in the future in today's political world, and models of interpersonal care. Dr. Lyle Duncan is the medical director of consulting services with the Coalition for Compassionate Care of California, an organization dedicated to empowering the people of California to make value-based decisions about their health care needs in times of serious illness and end-of-life issues. Dr. Duncan educates community groups and healthcare providers on end-of-life choices and offers private consulting for families regarding end-of-life choices, hospice, and care planning. She's also a staff physician at the Kentfield Rehabilitation and Specialty Hospital. For several years, I noted she worked as a volunteer for Himalayan Healthcare and spent time working in both Sri Lanka and Nepal. She's board-certified in internal medicine, infectious diseases with special interest in advanced care planning and advocacy, palliative care options. I just want to note in her case that part of her bio indicates that she not only does telemark skiing, which is quite strenuous, as well as surfing. So we have a very well-rounded panel here today. Sorry. So we are asking you to hold your questions till the end. There'll be plenty of time. They'll both be speaking through PowerPoints. The slides are available if you want hard copies today. So please welcome Dr. Lyle Duncan and Sarah Hooper. Thank you all for attending today.
Hello. Sure, that sounds good. How are we doing? Can we hear me okay? Volume good? Okay. Thank you so much for having us here today. We're really pleased to be here with you all. We're really pleased to also be reaching our HPL students who are watching us via live stream. Our plan for tonight is I'll spend the first half of our time together giving you an overview of the law and some of the issues in implementation. And then Dr. Duncan is going to spend some time talking about the experience in Oregon and Washington, since we have a number of years of experience and data under our belts from those states that will be instructive for California. And she's also going to be talking about, some of the best practices and challenges in having effective communication around these topics. Quick note, this talk does not constitute legal advice, nor does it necessarily represent institutional policy of UCSF Medical Center. I am not counsel for UCSF Medical Center, and I don't represent their policies. So if you have questions or you need advice about a specific situation, I recommend that you consult your institutional counsel and the specific policies at the place that you provide or receive care. And if you provide or receive care at multiple places, you may need to check their policies as they likely vary from setting to setting. Okay, so the California End-of-Life Option Act was enacted by the legislature and signed by the governor in fall of 2015. And in taking this action, California became the 5th state in the nation to legalize physician aid in dying, which is a very specific form of end-of-life care that is strictly defined in the law. The Act permits physicians to prescribe a lethal dose of a drug to a competent, terminally ill patient for the purpose of allowing the patient to end his or her life at the time and manner of his or her choosing. The law allows this prescription only under a very specific set of circumstances, and those circumstances are designed to ensure that patients who request this option are doing so knowingly and voluntarily and have had the opportunity to consider their other options. So I'm going to walk us through some of those details, but I wanted to first make a note about the significance of the law for patients' rights at the end of life. So the law has been heralded by advocates and by some as a major victory for patients seeking greater empowerment and control at the end of life. And it's certainly a significant piece of legislation in California. But particularly in the early implementation, I think that we have reason to temper our expectations somewhat about the impact of this law generally in end-of-life care. And the main reason I say this is that the law does not create a right to aid in dying. It simply allows willing physicians and willing patients the ability to pursue this option without fear of criminal or civil liability. It's a permissive statute, and it creates no affirmative right in the patient. And physicians and healthcare systems have the ability under the law to opt out quite broadly, even declining to provide basic information to patients is something that they can do. So patients who wish to learn about this option or pursue it are reliant on physicians and healthcare systems whose ethics and values around this particular option and end-of-life care generally is usually not transparent to them. So I wanted to make that point. In addition, the law is designed, it's inherently designed to slow patients and physicians down in making this decision. And the idea is that we don't like to think that these prescriptions would be issued incautiously. And so when you combine the legal requirements of the law with existing practical challenges inherent in our very fragmented healthcare system, we are likely to hear of frustrations among patients and family members who are attempting to access this law. And indeed, we already have in the early months of implementation. So for those reasons, I just wanted to sort of make that note that this is a very important piece of legislation, but it is not a right to aid in dying. And for the reasons I've mentioned, there are some legal and practical barriers that may be present for individuals seeking to pursue this option. For that same reason, I find that critics of the law who articulate a fear that it will be used to sort of coerce vulnerable populations into ending their lives prematurely, I also find those claims to be somewhat hyperbolic. So I'm here today to tell you what the law actually is and does, and hopefully we can penetrate through some of the high emotion that tends to come up around this issue. Okay. So the Act makes it very clear that patients and physicians who act within the bounds of the law are engaging in a practice that is legal and that will carry no civil and criminal consequences for the patient or the physician. So the legislature went out of its way to clarify that a patient who ends his or her life using this Act has not committed suicide, and thus physicians who have participated in this option have not assisted in suicide. Suicide still carries very serious civil consequences for patients and their families. That is still true in California. For instance, adverse implications for insurance coverage, for wills, for contracts, for other things. And a physician who assists a patient in suicide in California is still guilty of a felony. So what the law has done is basically carved out this situation in which we say this particular type of patient and this particular physician choosing this option in these circumstances is not suicide. Similarly, euthanasia and mercy killing are also still crimes in the state and are distinguished from aid in dying in that aid in dying requires a competent patient to voluntarily administer the drug to themselves and others. And others, including a physician, are not allowed to administer that drug to them. So that is the difference between aid in dying and euthanasia. So voluntariness and self-administration are the line here. So consistent with those principles, this is how the law has drawn those lines. So only an adult with a terminal illness. A terminal illness is defined as an irreversible or incurable disease in which the patient is likely to die in the next 6 months. That individual must have capacity to make medical decisions and to make this particular decision. The patient must have the ability to self-administer the drug. The patient has to be a California resident and has to be capable of pursuing all the steps in the law. So I like this photo of Jennifer Glass. She was one of the advocates who really helped push for this law. And I like this photo of Jennifer Glass because I find that it's sort of emblematic of the type of person who both designed this law and the law is designed for. And the reason for that is, she's very clearly very ill, but she has this very determined look on her face, right? So the idea behind this law is to empower patients and give them a sense of control. We know from the Oregon and Washington data that this is also the type of person who actually has used the law in those states. So we know that overwhelmingly the patients in Oregon who requested aid in dying under that law were white. They tended to be of higher socioeconomic status. They had insurance coverage. They tended to be from more urban areas. And importantly, last year in Oregon, 92% of them were enrolled in hospice at the time that they took the drug. So the group that tends to utilize this option is not actually, by any measure, a vulnerable population. And so I wanted to share that piece with you. So again, conversely, if the intent of the law is to empower a certain group of individuals, we are also seeking to protect a certain group of individuals. So who are we seeking to protect? Patients lacking mental capacity, so individuals who are not capable of taking voluntary, knowing action are excluded from being able to use this option. Patients who are unable to self-administer the drug at the time that they wish to take it are unable to use this option. And importantly, someone other than patient cannot request this option. The idea is that this must be a request that comes directly from a competent, willing patient to their attending physician. So this means that under the law, even healthcare agents, guardians, and conservators, even if armed with some statement, an advance directive or a living will or a post, that this is what the patient would have wanted, these individuals are not empowered to request this option on behalf of patients. So let's talk about making the request. If a patient wishes to make this request, he or she must make 2 oral requests at least 15 days apart. And they have to make 1 request in writing that needs to be witnessed and signed. So you can see the form that is actually in the law. This is what the patient would need to have witnessed and signed. Again, the requests need to be made directly from the patient to the attending physician without others present, except an interpreter if one is needed. And again, the requirement that these be made to the physician without others present is designed to allow the physician to make a determination that the patient is requesting this and is not subject to coercion or undue influence from other people. And in fact, as part of determining the qualifications of the patient, the attending physician is required to confirm their belief that the patient is not subject to coercion or undue influence. So attending physician responding to this request, and this is something that Dr. Duncan is going to talk about in much more detail, is and should going to be having a very in-depth conversation with the patient. And we can't, if there's nothing else that we come away with today, it's this moment, it's this conversation that is the linchpin of not just this act in particular, but of good end-of-life care generally. So the act contains a long list of counseling and informed consent requirements, so elements that the physician is required to discuss with a patient. So prognosis, diagnosis, alternatives, including hospice, palliative care, palliative sedation, voluntarily stopping eating and drinking, the risks, benefits that are attendant with taking the drug. And importantly, the law specifies that the physician needs to tell the patient that they have the option to receive the drug and not take it. So as you can see, sort of along the way, the law is making it very clear that this is not something that we want patients to be pressured into in any way, shape, or form. The attending physician also needs to determine if the patient is qualified. So are they an adult? Do they live in California? Do they have the mental capacity to be making this request, et cetera? The attending physician is empowered to make that a capacity assessment on their own. However, if they have concerns that there is the presence of a mental disorder that might be impairing the patient's judgment, the attending physician needs to refer the patient to a mental health specialist for further capacity assessment. But the mental health specialist referral is not required in all cases. In all cases, the attending physician does need to refer the patient to a consulting physician. And the role of that consulting physician is essentially to confirm the diagnosis and prognosis of the patient, to also provide an opinion as to capacity. This physician also has the duty to refer to a mental health specialist if we're not sure if this person has capacity for this decision, and has their own documentation. So in any case of the End-of-Life Option Act, the patient is going to need to see at least 2 physicians, possibly 3, before they can proceed. So the mental health specialist, since we're among a behavioral health group, the mental health specialist, the law specifies that this needs to be a psychiatrist or a licensed psychologist. They need to examine the patient and the relevant medical records. Over 1 or more visits, the law leaves it open how many visits are required to make this assessment. And this individual is obviously there to help determine if the patient has capacity for this particular medical decision, and that their judgment is not impaired by the presence of a mental disorder. So I may be speaking to the choir a little bit here, but for the benefit of for our students online and for others who don't know this, in California, a diagnosis of a mental disorder alone does not mean you lack capacity for medical decisions. And the reason for that is we don't assume that just because you have a cognitive disability, you are unable to weigh in on your own medical decisions, right? So it may be that you are unable to weigh in on this particular decision, but the fact that you have a diagnosis by itself is not enough to deny you the ability to weigh in. So that's why we have physicians who make individualized determinations of capacity based on where you are now, either in the stage of your illness or other factors. So if there might be questions about that, but we can talk about that more at the end. If the attending physician has determined that the patient meets all of the requirements, the consulting physician is in agreement, and the mental health specialist is also in agreement if that was needed, the attending physician can directly dispense the drug if he or she is authorized, or a pharmacist can dispense, either directly to the patient or by mail. And once the drug has been dispensed, there needs to be a report to the California Department of Public Health within 30 days. The California Department of Public Health under this law is tasked with tracking all of these cases and is keeping data that will be published to the public. So when it comes time for the patient to take the drug, the law again reiterates that the patient can change his or her mind at any time, regardless of capacity. Okay, so we bent over backwards to make sure that this individual had capacity to make this decision. But if for any reason the patient changes his or her mind, even if we're not sure that he or she is clear on the reasons for doing so, they have the ability to do that. The patient needs to be able to self-administer the drug. So under the law, another person can help prepare the drug, but the individual needs to actually be able to self-administer on their own. An individual cannot take the drug in a public place, so a park or an alleyway or a street or a place that is visible to the public. I think the legislature was maybe concerned about grand gestures at the end of life. Not entirely sure who put that provision in there, but it seems to be something they were worried about. And the law also says that others, including the attending physician, can attend, right? And then the patient is required to fill out this final attestation form, which essentially says that I, this patient, have decided to take this drug of my own free will. I was not subject to coercion or undue influence. And I understand that I could have changed my mind at any time. So if the patient does end up taking the drug and dying from ingestion of the drug, the attending physician will make a report to the California Department of Public Health within 30 days of the patient's death. Now, the statute isn't clear about what cause of death to list on the death certificate, but it's not suicide. So physicians should not put suicide on the death certificate. Common sort of advice that I've heard is to simply list the underlying disease. You can list the End-of-Life Option Act or not. But even if the End-of-Life Option Act is listed as a contributor to the death, the patient and his or her family cannot suffer any adverse civil, criminal, or professional liability. As a result of that, it will not affect insurance or contracts, annuities, wills, or other legal documents. And of course, the other biggie is that the physician will not be subject to civil or criminal sanction for participating in this activity. So as I alluded to at the beginning, we've sort of been talking about this process as though everyone is on board. But I think a major issue that we've already seen in implementation is a lot of providers' very deep ambivalence about their role in the End-of-Life Option Act. And that is true even among many physicians I've talked to who do believe that patients should have access to this resource, but they themselves feel very ambivalent about assisting in it. So what are opt-out physicians required to do? Very little, very little that they need to do. But again, as Dr. Duncan will talk about, good conversation is going to be absolutely critical. This is a real turning point in the time of this patient's life, and they need to have physicians. They need all of their requests and bids for information to be met with compassion and curiosity and a willingness to have a conversation. The End-of-Life Option Act doesn't, so physicians are not required to discuss the End-of-Life Option Act itself. However, somewhat confusingly, there's another statute in California called the Terminally Ill Patients' Right to Know End-of-Life Options Act. This was passed before the End-of-Life Options Act. So what physicians are required to talk about are all of the options other than the End-of-Life Options Act. So if you are an opt-out physician who wants no part of this, you are still required to talk to your patient about their other options. And I will just say that if your patient requests information about the End-of-Life Option Act, and it's the first time anyone has talked about end-of-life options, this is a big problem, right? We should be having these conversations much earlier. This is a pretty dramatic bid for information and for discussion about what is a really difficult topic. There is no requirement in the statute that an opt-out physician disclose their intent to opt out, but I'm here to tell you that hiding it from a patient is not going to be a good idea, and we've already had at least one case where this has been a problem. And finally, the physician is not required to refer or assist in transfer of the patient. The health system does need to cooperate in transferring the records of the patient. But unlike other end-of-life healthcare decisions, there's no requirement that the patient or family be referred to someone who will provide this service. The law also permits entire institutions to opt out. So we know that about 13% of acute care in California is provided by Catholic or church-affiliated institutions. And we know that all of those institutions are opting out of the Act. The Department of Veterans Affairs is also opting out, but for a different reason. There is a federal law that says that no federal dollars can be used in activities that could be construed as assisted suicide. So the Department of Veterans Affairs will not, and all of those providers will not be permitted to participate in the law. So what opt-out institutions do need to do is notify their employees if they're going to prohibit their employees or contractors from engaging in the End-of-Life Option Act on their premises or within their scope of contract. So you have to have notice. And these institutions also cannot place effectively a gag rule on their employees. So physicians who want to participate but are part of an opt-out institution can still provide information about the act to patients, can still talk about diagnosis and prognosis for the first part of the act, and can also make a referral to other physicians. So I think just sort of a note, a big picture note before I turn things over to Dr. Duncan. This law, there's a big gap between public perception and public attitudes about this law, and I think the medical profession's sort of view of it. The public, when Jerry Brown signed this into law, according to an IGS-UC Berkeley poll, the public favored it overwhelmingly by 76%. And in this political environment, something that was very interesting about what they found was that there was high approval even among Democrats, Republicans, and independents. So we can't seem to agree on much these days, but in California, there seems to be very high public approval of this law. And they also found that this crossed demographic lines. So across class and race and gender and socioeconomic status, there's generally a very high rate of approval. With one exception, among African Americans, there is a slimmer majority who approve of the law, but still overall approval. There's been a more cautious reaction from providers. The law, many observers say, only passed because the California Medical Association switched from actively opposing the law to simply being neutral. And that sort of was a sea change in physician opinion. But as I mentioned before, I think even among physicians who are in support of a patient's right to choose this option, it represents a big shift in the practice of medicine and how providers are trained to think about their role. And so I think, even in some of the reporting, we've seen that there's been a mismatch of expectations between patients who see their ability to access the law as being easier than it might actually be in reality. Determining institutional opt-in and opt-in status is difficult. Many institutions are still trying to determine their policies and are unwilling to share a lot of those details. I have a research assistant who's been trying to gather this information, and most of the time they simply won't give it to her. So we're still trying to figure out who is going to be willing to participate and who's not. It's also difficult to define opt-in and opt-out. Policies can range quite a bit. We will permit our providers to offer this option to patients, but not on our premises. Or, we're an opt-out institution, but giving information is okay. So it's, there's sort of a range. The LA Times reported that their sense of it is that most providers will opt in. There's a little typo there, but we know that at least 13% of acute care providers are opting out. The VA is going to opt out. And finally, Medi-Cal is opting in. So the state has said that Medi-Cal, the state portion of Medi-Cal dollars, can be used to pay for patient access to the End-of-Life Option Act. And not the federal portion, but the state portion. And they've set aside some budget for that. So I'm watching implementation, as I said, sort of at the beginning, with sort of tempered expectations about what this will mean in California. It's likely to be a very small number of patients who seek and actually follow through with this option, as Dr. Duncan will talk about in a minute. So I look forward to your questions, and I'm going to turn this over now.
Sarah, thank you. Wow.
That much better. Okay, good. Sorry about that. Thank you again, Sarah. That was lovely. And I want to remind our online listeners, of course, they know, and those in the room, that the UC school has great resources on this End-of-Life Option Act. So, as Stanley mentioned earlier, I'm a physician by training. Internist and ID is my background, but my passion really has become end of life and education. And I work entirely in that area now, and not at this time doing any direct patient care. And I'm very much involved in trying to change the way care is delivered for those of us who need it and those of us who will be needing it, which, to my knowledge, is everyone. I have no personal disclosures to make. The organization that I work for, the Coalition for Compassionate Care, is absolutely neutral on the End-of-Life Option Act. We do not suggest or support that it be implemented, and neither do we dissuade anyone from pursuing the gathering of information about this option. We provide information to the public, to providers, and to organizations as they are considering the complexity of this legislation and how they're going to be developing their policies going forward. And as Ms. Hooper mentioned, the development of policies in that setting is very complicated, and I think her word range is very good. Spectrum is another way to look at it in terms of the response among organizations and providers as well. So my task this evening is really to talk about the talk and to talk about the communications that need to happen as part of this legislation, but really as part of all good end-of-life care. So I'd like to do that by placing these conversations in a little bit of context and understand that this end-of-life option, this particular aid in dying option, is really part of a bigger story in the landscape of healthcare across our country and really globally. And in America, where we have a very complex and often quite siloed health system, these questions of how we do a better job caring for patients at end of life are really, really at the top of a lot of radar screens right now. And there are many, many reasons for that and a lot of very good solid data that backs me up when I say that we have a long way to go to creating high quality end-of-life care experiences for everyone. So talking about end-of-life care occurs in this complex world that we live in very complex healthcare system settings, and across a variety of healthcare settings, regional areas of disparity and regional areas of richness in the availability of healthcare options. Social media has changed the way that we communicate with our families, our friends, with our healthcare providers, and with others. And in terms of news spreading, we see things take off and change and ideas spread in a way that is fundamentally different from, I know, when I was in high school. I like Paula Spann's phrase, the new old age. I don't know how many of you follow that column in the New York Times, but it is an age of a new old age. We are living longer with greater complexity of disease, with higher burdens, both of disease and a higher need for care, a greater likelihood that we will be dependent on others in our old age. Some of the diseases that we tend to die from, chief among them heart disease, cancer, and end-stage organ disease, such as end-stage lung disease, are being aggressively treated at these times, and we are seeing drastic differences between now and 50 and particularly 100 years ago with respect to these disease entities. And as our lifespan increases, we become at higher risk for having frailty, disability, and dementia in the waning years of our lives, quite simply because we will survive to get those things, because our heart disease and our cancers are being better treated. So medical care is more complex. The care decisions that we face are not just one, but many and numerous and subtle. Many providers struggle to describe the nuanced differences in the pros and cons, benefits and outcomes, and likely expected results from various different interventions, and you apply that to a wide variety of patients and incredible genetic diversity, it's very hard to predict what will happen with any given patient at any given time. Over 80% of us in this state and nationally really believe that this type of planning and these discussions are important, but fewer than 25% of us actually sit down, talk with our families, and write out a plan. Now that number is a little bit higher or lower depending on which segment of the population you're looking at, but you can bet it's between 25 to 35% roughly for average public. Over 70% of us say that we would like to die at home. That is no surprise, right? We all imagine a quiet, peaceful, quick, and painless death. I really have never heard someone ask for something else, quite honestly. But the reality is that the vast majority of us all across the country are still dying in facilities, away from our families often. So choices in end-of-life care, one thing I really have appreciated about the passage of this legislation is that it has raised to the forefront of everyone's imagination and utter consciousness the fact that these conversations need to happen, at least in some form, whether it's played out in the media or elsewhere. And I can tell you that almost across the board, providers who are engaged in caring for patients who are facing end-of-life choices have had a very big aha moment when a piece of legislation was passed that suggested them exactly how they should be having discussions about end of life with their patients. And they all turned to themselves, many, the majority of them, and said, I really have no training in how to do this. I am not comfortable with it, and it's tough. How am I going to do it? So you can look up the Hartford poll, and if you'd like that link, just let me know. But it suggests that most of our providers are not well trained and not comfortable in having these discussions. Their electronic health records, if they have them, are not supportive to the work that they do, so that when they do discuss goals of care and care options, they may not have a place to record it properly. If they record it, it may not be retrievable. And so that information, even if they do gather, it may not be available to family or other healthcare providers at end of life. These are fundamental problems with how we deliver end of life care. New discussions are happening. The community is right to be concerned, and lots of activity going on in that area. Many unanswered questions, and we have a very, very long way to go. I think Ms. Hooper pointed out that in time, there will be a long period of the dust settling as we really see what's going to happen in terms of access to this particular option and in terms of access to good palliative care and good end-of-life care for all of us. So now I'll take a few minutes and talk a little bit more in depth about the Oregon experience that you've heard something of. Most of these patients in Oregon in their 20-year experience who availed themselves of aid in dying medication were 50-50 male-female, about 50% married, most of them age 70 or older, overwhelmingly insured, and overwhelmingly participating in hospice. So a fairly significant, a fairly specific segment of their population. Now, I would like to take this opportunity to point out some of the differences between Oregon and California. That state has a usual population of about 3.8 million. Our state, as you know, has a population of over 38 million. They are overwhelmingly Caucasian, 70% or more across the state. We are not. Not only do we have majorities and minorities represented in varying numbers across our counties, but approaching in some counties, 50% of the families have a non-English speaking as a primary language in the home. So quite a different demographic landscape that we are now bringing this legislation into. And I would expect that our differences in demographics and our differences in culture and perspective and other differences will play out as we see what happens with access and engagement. So patients by diagnosis, not surprisingly, most of the patients over the course of the experience in Washington and Oregon have been treated for cancer and are dying from cancer at the time that they are engaging with aid in dying. This is just the last couple of years, but all of this data is available online through the Oregon Public Health Department. They have an increasing number of heart disease patients, and also a significant number of patients with ALS. That is also going to be a difference in our state, partly because the ALS population, which is amyotrophic lateral sclerosis, which is the degenerative disorder that leaves you paralyzed but cognitively intact, will make it challenging for patients to self-administer. And again, because the legislation that's been developed in our state errs on the side of caution and protection, we also find that it may be applicable to a more limited segment of the patient population. But we'll see. Prescriptions versus actual deaths. So for all the patients who request information, some of those go on to complete the process. Some of them complete the process to the extent that they actually request and receive the aid in dying medication. But not all of those patients take the medicine. Many will die at home on hospice. Many will die from their underlying disease before they take the medication. Roughly, in Oregon, they've seen over 50%, 50 to 60% most years. same data represented differently. Washington is different. Now, Washington has had their legislation for about 5 years. They have seen that in their state, upwards of 80% of the patient population who requests aid in dying medication actually ingests it and dies from their ingestion. So much higher percentage. And what will these numbers look like in California? We really don't know yet. We will have our early experience to look at, we hope as soon as the middle part of July of next year, to look at the initial data of the first 12 months of rollout. Anecdotal information is available now, but in terms of what the overall percentages are going to be, it's very hard to predict. Why do patients request this? You heard a little bit about this from Ms. Hooper as she described the empowered, determined patient who is wishing and hoping for an end-of-life care experience that is consistent with their own individual values, beliefs, and specific desires for autonomy and control in the end of life. So losing autonomy and becoming dependent on others and having lack of quality at end of life as that individual defines it are primary motivating factors in seeking aid in dying. So avoiding a specific type of suffering that they define as unacceptable and wishing for control over their end-of-life experience in a way that is at the furthest end of the spectrum in terms of having control over the time and place of your death. Listed in different format, a number of really terrific researchers have scoured the Oregon data and the early Washington data to ask these same questions, and we do see these same things, the same themes coming out over time. Perceived lack of quality, loss of meaning at end of life, loss of dignity, and wishing to avoid pain and suffering and physical dependency. And importantly, the way that they define it, not the way that you or I or someone else might define it, but their own definition of a life without quality and meaning and a wish to avoid specific suffering. Other themes that come up but are usually not at the top of the list include being a burden on family and financial concerns. So can conversations that we have, both at end of life and prior to that, be helpful for patients and families, logistically, emotionally, contextually, financially? The answer is yes, and there's very good data to support this. We call these conversations part of good advanced care planning. Now you could say end-of-life planning isn't very much in advance, but it's really all in advance of death. And to that extent, it is advanced care planning. We're planning for something that we anticipate happening in the future. And the way that we do that is first by considering our own wishes, recording them, and then having those wishes honored. This is one graphic that we frequently use to describe how advanced care planning should be occurring across the continuum of our lifetimes and across the continuum of healthcare. And you can see right here, I love to point out it's really important that what's holding up this whole stair-step progression is the word conversation. In the end, it's the conversations that we have that will support us having our wishes honored, more so than any individual piece of paper. Key documents are critical. Of course, the Advanced Healthcare Directive plays a very specific role by legally appointing a healthcare decision maker. And the post-form physician order for life-sustaining treatment plays a very important role in specifying choices in care when end of life is close, and helping patients both to choose and avoid care that they want or don't want in terms of life-sustaining treatments such as cardiopulmonary resuscitation, ventilator, ICU care, and long-term tube feeding. The conversations that we're talking about occur down in this lower bubble. So you could imagine that if you're talking with an 18-year-old just about basic advanced care planning, it's a pretty straightforward conversation. There are a few things to consider, accidents and trauma being the main cause of death for us when we're young, But as we move towards the end of that spectrum, these conversations get very complicated. There are different people involved. Medical decisions are much more complex. So when time is very short, there's that much more pressure. There's that much more emotional context. There's preemptive grief and bereavement that's beginning to occur in the family and for the patient. These are weighty, challenging conversations. Patient and family are trying to establish their own goals and values, and if they haven't had access to prior advanced care planning conversations, they may never have learned how to express these ideas. They may not know what questions to ask. A lot of uncertainties. Making a prognosis for a patient sometimes is very challenging. Providers face challenges. Many of these decisions will occur in the middle of this context of this organization of bubbles in an ethical setting where people are making choices that either they or their family or segments of society may be uncomfortable with, may be challenging, may cause moral distress. Patients have certain rights. Providers have certain rights and duties as well. The Physician Aid in Dying, the California End-of-Life Option Act, provides one specific option to patients at end of life. All right? And we know from demographic data that we've looked at that a certain number of patients will want this. It is not likely to be more than 1% or 2%, maybe even if it's 3%. That leaves the rest of us, 97% of us, that need to talk about these options as well. Options with an S, not the option with no S. AB 2139, which is the Right to Know Act that Ms. Hooper referred to, indicates that any provider who is caring for a patient who has a prognosis of an estimated time frame of 12 months, not 6 months as in the other piece of legislation, but 12 months, has to tell their patient that they can receive information about all the different types of care they can receive in end of life. And if the patient says, yes, I would like to receive that information, then the legislation specifies what the provider should be talking to, should be listing and discussing with the patient. The exception, as Ms. Hooper pointed out, is aid in dying medication, which does not need to be discussed in this context. We generally wait for the patient to bring up that topic. So medical topics for discussion can include prognosis with and without curative treatment. What would that look like? What would it feel like? What might happen? What are the choices for life-sustaining treatment? And what effect would they have on that individual patient, on their lifespan, on their quality of life? What does it look like to get aggressive and sufficient pain and symptom management? And how can the patient gain access to that? Palliative care, what is it? How do you get it? What makes sense? Hospice care, when am I eligible? When am I not eligible? How can it help my family? Voluntary stopping of eating, drinking, and palliative sedation. All of these are part of the discussions around end-of-life care. Discussing medical and personal outcomes differently. It's very easy to measure physiology. We talk about success rates with certain interventions. That's usually with respect to measurable medical outcomes. But I can tell you that for patients in severe illness and facing end of life, what they care about is actually how they're living, their level of function, whether or not they're in pain every day. And so the proper way to phrase the question from the family would be, well, if I have this treatment or if we pursue this route, what will that look like for me? How will my days be? Where will I be? How will I feel? What's my quality of life going to be like? And how will I be functioning? Which is very different from saying, yes, that medication will lower your blood pressure. Individual choices that we make are influenced by a number of different things, and you can guess what they are, but certainly by our demographic situation, by our socioeconomic status, by our ethnic and spiritual affiliations, by our life experiences, by our prior experiences in healthcare, by family traditions. Every conversation that we have in that setting is cross-cultural, because my life is not the same as your life. Even if we may fit into the same ethnicity, the same demographic setting, the same county, the same size house with the same number of toilets, it doesn't matter, because our life experiences and our deeply held beliefs are going to be different. And so whenever I talk with patients and families, I try to remember, and we all should remember, that every conversation we have is a cross-cultural conversation. So how do we maintain dignified respect and achieve efficacy as we have these really challenging conversations? And as we talk about aid in dying, the patient may be quite comfortable and ready to pursue the End-of-Life Option Act, but the family may be having a hard time understanding. The provider comes in the middle and has the opportunity to smooth out that water, to help the family understand the patient's perspective, and to help normalize some of the talk that is going on in that setting. When we have these conversations, there's a lot of background work sometimes that needs to be done, and sometimes not so much. We might want to anticipate what the setting is, find out who's going to be in the room, decide what we're going to be discussing, but a lot of times they come as a pop question. So again, this is a nice list, I think, of topics that can come up or should come up when we're talking about facing serious illness or end of life. They should all be touched on in the setting of end-of-life care. And for any patient pursuing aid in dying or other end-of-life options, these things need to be attended to. Providers can take training and practice and learn how to use some simple tools and techniques, familiarize themselves with some questions that will help them to open these conversations, to move the conversations forward so that the patients and families can get some of the information that they need. Ultimately, end-of-life care for every patient, whether they're pursuing aid in dying or exploring other options, we should be looking at a fairly complex array in terms of the discussion that we're having, in terms of the role and engagement of family and caregivers. We should be looking down the road at where they prefer death to take place. And we should be helping them make care choices that will allow them to achieve goals that are specifically meaningful to them, aside from the measurable medical outcome. It's really about the living. We talk about the dying process and we talk about end of life, but I can tell you that, to the extent that if death is right here, this is all life. This is all living. This is still living right up until the very last moment. And what we want to create is for that pathway to be as smooth as possible, as thoughtful and supportive as possible, and to happen and unfold in a way that makes sense and provides value for the patient. In addition to, of course, relieving suffering and providing good, high quality, very competent, culturally appropriate, and dignified medical care. So I will stop there, and I've listed some resources in your handout. Please feel free to contact our organization if you'd like to have these links sent to you in an email, or you have additional questions or concerns. We will try to answer those questions. So thank you for your patience. So I think we'll open the floor for questions.
We have a mic, which I'm going to walk around when you have a question, so if you can hang on, I'll bring it over to you so it'll capture.
I'm going to stand because I can't see those folks.
So my question is, how much does finances, now that board and care and SNF facilities cost so much, how much is that gearing Or how much is that part of the discussion about ending life?
Well, providers aren't required to discuss personal finances with the patient, but best practices strongly suggest, as you've seen from my slides, that we at least inquire about the financial concerns of the family for those reasons. And if we're doing advanced care planning and end-of-life care planning well, we're not waiting till the last minute. We're planning in advance for the necessity for board and care or for facility living and so on. But many, many families face profound challenges. And in case you don't know it, medical costs are the #1 cost for personal bankruptcy in our country.
So if they're at a board and care, does the board and care have to opt in order to have a patient there who has a drug that they can take to end their life? Because they're caregivers too.
Right, exactly. So as Ms. Super pointed out, and I'll let her speak to this as well, of course, is that every individual facility and every individual person, be they pharmacist or therapist or board and care facility or nursing home or tiered living, assisted living, or a hospital, every organization has a right to not participate and to not have aid in dying medication ingested on their premises and to write a policy. And every person within that institution, regardless of whether or not the organization has opted in or out, has the right to opt out. So someone might be working in an institution that has an opt-in policy where they have a support network for patients who are seeking aid in dying. They may have social workers and others that are there to assist the patient, but that provider can still say, I won't be participating. So yes, any individual board and care facility, depending on their licensure and their board structure and so on, they would be crafting their own policy on this. And then each person in there, each individual caregiver living and working there could opt out.
Yeah, so this is sort of what I was alluding to in the first part of the talk. We haven't had Marcus Welby style care in decades, right? So we don't receive our care from one physician who's known us our whole lives and delivered us when we were born and carries us, follows us back and forth to the hospital. We have a very deeply fragmented healthcare system, and particularly for individuals who are encountering long-term care, they see a number of specialists, they're in boarding care, they're bouncing back from boarding care to a hospital. They're being cared for by very large teams, and there can be a whole, any person in that individual life can decide that they don't want to have anything to do with this process. And so I think what some facility, each facility is having to decide what its policy will be. I think even within big health systems that are generally supportive of the act, they're having to find sort of specialized teams that they can identify ahead of time that might be willing to take this on. So for instance, can you identify a mental health specialist that is willing to take these consults? Can you identify a pharmacy that's willing to issue the prescription? As I said, this is not a right. It is a permission for anyone who's willing to be involved to engage in this activity. And I think the reality is that our healthcare system doesn't make healthcare easy, even under situations in which everyone thinks it's a good idea and is on the same board, on the same page about treatment. So you inject something that generates a lot of deep feelings, and I think access is going to be a very real challenge.
Thank you.
With regard to the statistic that 70% of Californians said that their preferred place of death is home, has there been any surveys of caregivers and what their preferences are vis-a-vis home versus hospice? And with respect to the other statistic about only 25% having their wishes recorded, I wonder when there was a discussion of having end-of-life care or living wills being paid for through Medicare at the time that the ACA had been passed. What a pity that that hadn't gone through. That perhaps we would have more people having signed on to living wills if that were a benefit that was provided under Medicare.
Okay, so that's two questions. One is discussions about end-of-life care and advance directives and advanced care planning and choices in end-of-life care are billable now under Medicare, and most publicly held insurance organizations are following suit with that. So your Blue Shields and so on are willing to likewise adopt those same CPT codes, we call them, and to reimburse providers for having these challenging conversations and for doing planning with patients. Now that said, these conversations, as you could guess, are time-consuming and complicated, and they may not fit. They very often do not fit easily into the usual workflow for a provider who is seeing a patient on average every 15 to 20 minutes, particularly when those patients are ill and have complex medical care needs, which is most of this population. So since those codes are relatively new, I think that we will hopefully see in the future healthcare organizations and individual practices find ways to create workflow around this need and to find ways to allow their patients and families to participate in conversations and advanced care planning. Again, it's more of a structural issue. The payment now is there. The incentive, if you want to call it that, is there on many different levels. And some organizations have addressed this quite broadly and are implementing life care planning services and comprehensive advanced care planning programs, which are starting to take off. But once again, we have a very long way to go. And I'm sorry, after that long-winded answer, I lost track of the first part of your question. Oh, the caregivers. So that's a really good question. I'm off the top of my head. I can't recite for you data, but yes, there is data. We know from looking at burdens of caregiving among that population that it's really quite profound, and that burnout and exhaustion are common, and that support and respite care for patients and families who have 24-hour care needs for a very ill individual at home are very, very real and impact the end-of-life situation. So there is a need for additional support within the community to help families to cope with an end-of-life process where the caregiving needs and burdens are quite high, and they hope or wish to support and honor the patient's wish to die at home. Or quite honestly, maybe they can't afford facility care for that patient, which is very often the case. So they have no choice but to pursue home care. And then we're looking to our community, to our friends, and to our family, just like we did 100 years ago. So I can only imagine that surveying caregivers specifically about aid and dying, that there would be the same level of ambivalence that we see across the board in the public. But I think we can say comfortably that caregivers always need support, and they certainly generally need a little bit of respite for the intensive duties that are necessary at that time. One of the benefits of hospice is at least they have access to some social support services and bereavement care and counseling, although it doesn't provide, of course, 24-hour nursing care in the home, which is largely provided by the families. One of the largest unpaid segments of our workforce, right?
Yes, I have a question from one of our participants in the live stream. They're asking, why is a physician tasked with determining that all legal requirements are met? Why isn't an attorney involved to make the determination of legal requirements?
Other than the fact that physicians don't like attorneys hanging out at the bedside, because we ask physicians all the time to make a lot of legal determinations. So it's not unusual to task a physician to make an assessment of capacity. They already are tasked with doing that under the California Health Decisions Act. We ask them to certify somebody's disability for purposes of ADA or access to in-home supportive services. It sort of comes with the job. The ability to drive. There are a whole host of things that we ask physicians to certify. And I think, in keeping with the idea that this is meant to be a good quality discussion between the physician and the patient, without a lot of external interference or coercion, I think the idea is to preserve that one-on-one relationship as much as possible.
Yeah, does the California law contemplate any kind of mechanical assistance for someone who has a physical disability that would prevent them from being able to successfully administer the drugs?
The law does not contemplate any accommodations for someone who isn't able to self-administer the drug.
So if someone had ALS, they would be kind of out of luck.
Most of them, yes, depending on the stage of disease. And yeah.
Same for signature?
Same for signature. I mean, I think I can't imagine a situation in which a patient wouldn't be able to sign but would be able to self-administer the drug. I think, was that your question?
One could swallow, so it could be somebody could make up a drink and they could use a straw to ingest it, but they could not sign.
I'm a little bit hesitant to give specific sort of suggestions about how to accommodate that situation. I know that in Oregon and Washington, they have had some creative ways of getting around the self-administration requirement, but I'm not going to sit here and tell you how to do that.
But from a terminology perspective, their legislation is different. They use the term ingestion rather than self-administration, so that leaves them a broader option, for example, for a caregiver to hold a spoon or a cup or something, which would be considered contrary to the letter of our law here, where the patient is technically required to hold their own cup. The use of straws is concerning on a couple of different levels, primarily medical ones.
Yeah, I mean, California, it's certainly a much more affirmative requirement that the patient be able to hold and administer the drug on their own. But yeah, the specifics of that, I prefer not to get into.
Right.
This is more of a clinical question. I am a hospice nurse, and we're having frustrations with patients now who have cancer but don't want to take any pain meds because they want to have the mental clarity to ask the physicians. So because there's a 15-day period, I'm trying to find a convincing argument or tip for the patients so that they are willing, so that they're not afraid that their mental clarity will come into question because they've ingested narcotics for their pain.
Well, if they have known and predictable sedation from particular pain medications, we would expect that to wane as the medication is processed, metabolized, and leaves their body. So in the way that capacity can fluctuate on a day-to-day or hour-to-hour basis, I can't see a reason why they wouldn't be able to safely take their pain medication and then stop it at a point when they know they would have enough days to kind of clear it from their system before their next interview with their provider, their participating provider. I would also reflect back on the wording that we're talking about. So lacking capacity in the moment, the physician would be able to hopefully understand that, hey, this is a medication side effect potentially. Why don't we reschedule the visit? We would do that under other circumstances for other reasons, and altered cognition from pain medication induced sedation or other cognitive side effects is not the same as an underlying mental disorder, which is the terminology that's used in the legislation.
I wanted to ask you about what looks like some kind of inherent coercion to me of poverty itself, because people wouldn't have these resources for the other options, and also the secularization and materialism of our society, where a lot of people may feel, well, if I can't work or I don't have good benefits, then, it is my moral responsibility to die. So that's not like a personal, maybe coercion by the family member or whatever, but I mean, I've seen this in my family, and I thought it was a sign of depression, actually. But anyway, could you discuss that?
Sarah, do you want to start with that? Or you?
Yeah, I certainly think that there are many unfortunate ways in which, as a society, we communicate that certain individuals are less worthy than others. And so I very much am sympathetic and an ally in combating those sentiments. I don't tend to feel that this law, if read as it's written, communicates that sentiment or permits that coercion. And I say that because the individuals who are, the small range of individuals who are permitted to request and pursue this law are already dying. It's a very short window in which individuals have to request and pursue this option, and there are many steps that they need to navigate. The law is also very clear that an individual who is pursuing this option as a result of coercion is not engaging in aid in dying, and anyone who is promoting or assisting in that is still committing a felony. So I think the legislature very clearly was attempting to provide an option to a small group of people who are empowered to pursue that option, and to take steps to protect those who should not be taking advantage of that option. So my view is that I am very sympathetic to a concern that this law might be perceived or used in an inappropriate way. And I would just say that as written, I think the legislative intent is very clearly not that. And so, I think there are many things that we need to do for our vulnerable communities to improve health care, and those occur much further upstream and across the lifespan into end-of-life care.
Hi, I have two questions. I know that you said before that being diagnosed with a mental disorder doesn't necessarily mean that this disqualifies you, and I'm wondering if there is any data being recorded on anyone previously diagnosed or currently at the time of talking about the end-of-life option, diagnosed with any mental disorders or any comorbidity with the people already on the list. And my second question would be, what is the training now for physicians and healthcare providers, and how is that being decided, especially in regards to cultural, just being culturally aware in those kinds of conversations?
Sure. So being culturally aware, for most provider education, with few exceptions, they have to pursue their own education and training beyond their professionally required training. If they have an area of interest, such as palliative care or end-of-life care, they're independently pursuing educational opportunities in that sphere. And so the state, in passing this legislation, the state did not mandate or recommend or specify or direct either the California Medical Association or other governing bodies of physicians to mandate any specific training. So there are, there has been discussion about it, I think, about how to address the needs of providers in this area, but at this time, there isn't any mandated specific training. And I'm sorry, go ahead.
And do you know
wanna
if
add to that?
I can't remember if I'm not aware of any data on the,
Comorbidities.
on the, mental health status.
Yeah, neither am I, but I can give you a couple of pieces of information. One is, some degree of depression and sadness is very common at end of life. There is a self-grieving that happens and bereavement, and we call that a reactive or a situational state of depression. So that's common and measurable in populations facing serious chronic illness or end of life. And whether or not that mood disorder or another mental disorder is impacting judgment is really the question in balance for participation or for purposes of participation in Aid and Dying or in the End-of-Life Option Act in California. And that's an individual provider judgment. There certainly are some mental health diagnoses that would raise some red flags, but there's a very specific process required and described within the legislation that the physicians have to go through in order to specifically determine that the patient is capable of and is participating in a fully informed medical decision. And if they are not doing that, if they are unable to meet that, or if the physician has any reason to doubt or have concern, then the patient has to be evaluated by a mental health professional of a fairly high degree level.
This is
Does
a
that
related.
help?
Oh, I'm sorry.
Yes.
This is a related
question? Okay.
Thank you. Yeah, I just had a question as a mental health specialist. What is the threshold? Because some of these reasons for dying, they're very similar to depression. And, what if you do diagnose someone with depression or an adjustment disorder? Does it have to be a long-standing depression? What's the threshold for that determination? Because, for us, we're assessing things like suicide and risk and, sometimes by definition, there is an impaired judgment associated with a desire or a long-standing hopelessness. So what is that threshold for this mental disorder and impaired judgment related to that?
Yeah. Well, that is really an excellent question. And of course, the legislation does not specify because that is probably a very long discussion. And I look forward to the class that UC Hastings is going to be putting on for mental health professionals vis-a-vis, the End-of-Life Option Act. It's not specified. It's being much talked about. As you point out, it can be and often is quite a nuanced determination. By and large, though, the patient population that's wanting to participate in this way is fairly well characterized as being highly empowered, clear and persistent in their thinking, so they're not changing their mind every other day and on Monday saying one thing and Wednesday saying another, so that they can reiterate and teach back their own decision-making process in such a way as that it appears to be well-informed even despite a coexistent sadness or grief reaction. But how that is exactly going to be documented or borne out over time, we are now in that learning process. And I think during the next year and even now, there are some mental health associations that are having their yearly annual meetings are going to address some of these topics. And we look forward to those convenings. Well, they have different requirements in their legislation, of course, as far as involvement of mental health professionals and the way in which those things are recorded.
Great. A question over here is, does the experience in other states indicate that a few physicians will become specialists in participating under state law and that most physicians don't sign on to participate at all?
Yes. In short, So in general, a request for the end-of-life option in the other states, and we anticipate this is going to be true in California, is a rare event. 1% of the patient population, maybe up to 3% of the patient population is ever going to request and follow through with this option. And so even for willing sort of participative physicians, they're not going to see this often enough for this to become to get good at it, for lack of a better phrasing, not to be glib. So there's sort of like this practical issue that this is just not coming up enough for physicians to integrate this into their practice. And then, of course, there are the objections for reasons of conscience or other reasons that physicians just simply don't want any part of this. And then, as we mentioned before, there are, because of the reasons of fragmentation in the healthcare system, it can behoove healthcare systems to identify specialist teams that are sort of at the ready when these issues do come up. Because it doesn't make sense to then have to train every single physician every time. Often the patient doesn't have that kind of time. So I think for a lot of different reasons, that's been the experience in Oregon and Washington. If I were a betting person, I would say that's going to be the experience in California, but we just don't really know. What's your projection?
I would agree with you. I think that there is not going to be in our state any kind of a registry of names of participating providers. We will know or can know at some point in time which larger healthcare organizations are opting in or opting out, but private and individual physicians are making their own choices, and most of them, for reasons of privacy, are not broadcasting those choices. Many of the providers I've talked to have said, for example, well, I'm undecided, or I think I could see myself helping a patient in this way, but it would need to be one of my patients, somebody that I know very well. There are others that say, well, I understand and respect someone's right to gain access to this option, but I would prefer that I not be the one writing the prescription. So we're all over the map with that, really.
There'll be time for one more question.
So I've worked with a couple of people using end-of-life options since June. And I want to see if you could comment on the policy question that arose from the pharmaceutical company's perspective. So once end-of-life options came into play in California, there suddenly was an enormous increase in the cost of medications that needed to be purchased. And those medications are not covered by Medicare, they're not covered by Medicaid, and people need to pay privately for them. And the prices were increased 100-fold. So is there anything that either of you see coming down the pike to address? It's an access question. It's I think it's an ethical question also about how can people manage to purchase the drugs if they really do want to use this option.
Yeah, it was very distressing for a lot of patients and a lot of providers and even many concerned pharmacists across the state when they saw those prices changing literally in advance of the legislation becoming active, and they had been going up for some time. It's not to say that they just suddenly went up overnight. They had been climbing, and there were fewer and fewer manufacturers for the particular drug that you're mentioning, which is probably the top choice. But that being said, there are other options that do work and can work for some patients that are a tenth of the cost. And so for providers and medical teams and pharmacists who are willing to do the research and reach out, we know that there are ways around that cost. And in terms of market response to or legal repercussions for a pharmaceutical manufacturer that chooses to take advantage of increased demand, I am not an economics professor. I wish that there were more compassion in the world in general But yes, people are finding ways around it. It can be challenging, but I think, as rapidly as we see medical care changing and medical interventions and options and new drugs coming and going from the marketplace, we may see a substitute medication, particularly now that this legislation is passed and this is a legal option in a state with a population as large as ours.
I want to thank you all for attending, both here and online, and I really give a great round of appreciation for these two outstanding experts in their field with both their passion and their expertise. So thank you very much for coming.
Yeah. Thank
and
you,
the team
Mr.
at Busy
Weisman.
Life, and take our courses and workshops and study up, because this is a fabulous opportunity to learn how to deal with this particularly emotional issue that we'll all face. So thank you very much. Good night. Have a good evening.
Thank you. Yeah. You gave a beautiful presentation.
Oh, I thought
Such a lovely, such a nice way. No, well, probably because you've given it so many times, but I've heard a lot of people